All right, everybody, thanks for joining. Today I'm Luke Burton. I'm filling in for Eric and Vidit Bhargava as the moderator. Today we have Ryan Desanti, a pediatric intensivist at St. Christopher's Hospital for Children in Philadelphia. He did his pediatric critical care fellowship at the University of Wisconsin and trained under Dr. Avni Al-Subu. He is a lung ultrasound expert, and so he's going to give us a lecture on lung ultrasound today. Thank you, Ryan.
Yeah, thank you, Luke, and thank you for having me. So by the end of the presentation, hopefully learners should be able to identify normal lung ultrasound anatomy, including rib shadowing and the characteristics of a normal pleural line, as well as the pleural line's relationship to A lines and to the ribs, to differentiate E lines from A lines and Z lines from B lines, and then identify abnormalities of the pleural line, including pleural sliding, lung pulse, and lung point, and then identify the absence of pleural sliding using M-mode. Learners should also be able to identify the presence of extravascular and extraparenchymal lung water. Recognize that increasing extravascular lung water is associated with an increasing number of B lines. Recognize the clinical utility of lung ultrasound scoring systems in clinical care, and differentiate characteristics of simple and complex effusions. And then finally, learners should be able to differentiate potential causes of pulmonary consolidations, including differentiating small consolidations from large consolidations, characterizing the borders of consolidations, characteristics of bronchograms, and then recognizing pulmonary hepatization. So ultrasound waves are scatter at air interface, and so historically have been thought that lung ultrasound provided little to no clinical value. This was until the early 2000s, when a French group led by Dr. Lichtenstein initially published research using findings in lung ultrasound. And so artifacts which are created by the pleural line in lung ultrasound can be correlated with both parenchymal and pleural pathology. And understanding these easily recognizable artifacts can make point-of-care lung ultrasound useful in the clinical care of ill patients. There is a good amount of evidence for use of lung ultrasound across a range of patient care domains. It is most well established in adult acute care, where it has demonstrated high sensitivity and specificity for differentiating COPD, exacerbations in asthma, status asthmaticus with pulmonary edema, pulmonary embolism, pneumonia, and pneumothoraces. There's also a high level of evidence and good evidence supporting use in neonatal intensive care, including high sensitivity and specificity in differentiating transient tachypnea of the newborn, neonatal respiratory distress syndrome, neonatal pneumonia, and pneumothoraces. And there's increasing evidence for utilization in pediatric care, including use in emergency departments, in critical care units, as well as on pediatric wards. So just as a case example where point of care ultrasound may be helpful, last time I was on service, we had a 4-year-old male who was transferred from the pediatric floors for worsening respiratory distress. He had a history of asthma as well as sickle cell trait, came in with complaints of fatigue, fever, head and neck pain, as well as swelling of the head and neck. He was admitted for a diagnosis of cervical lymphadenitis, as well as tonsillitis with a small retropharyngeal abscess. And he had been admitted for a few days to the pediatric floor. He was currently on high flow nasal cannula, 25 liters per minute, which was about 2 ml per kilo, with FiO2 of 0.25. And then he had worsening respiratory distress, which prompted a rapid response team evaluation. During that time, he was afebrile with heart rates in the 140s, respiratory rates 40 to 50 times per minute, a blood pressure about 90/60, and saturations in the mid-90s. Chest x-ray at the time of the rapid response looked like this. And then the radiology read said that there was interval progression of previously seen multifocal consolidations, which were concerning for pneumonia and likely a small left pleural effusion. So when using lung ultrasound, should typically be used as a supplement to the history and physical examination. This is similar to how we would typically use chest X-rays. There are multiple proposed benefits of point-of-care lung ultrasound, especially when compared with chest X-rays, which is kind of the more standardized examination technique in pediatrics. Some of these proposed benefits include rapid time to image acquisition, with a mean time in studies to completion of a full lung ultrasound of 7.4 minutes. This can range between 2 and 20 minutes, but these exams can be much quicker if there's a pointed question which you are trying to answer with the exam. Another proposed benefit is real-time interpretation and integration into patient care, as well as promotion of time spent at the bedside, and easy repeatability, as well as low cost. Though some may argue that these proposed benefits are also downsides, because also need to be spending those 7 to 10 minutes at the bedside of the patient and can't be doing things with other patients. And takes time away from other patient care and other responsibilities that you may have. So lung ultrasound relies on examination of the pleural surface at multiple sites over each hemithorax. For this exam, we can use either the linear probe or the phased array probe. Usually in my practice, depends on patient size. If patients are generally thin or of younger age, I will use the linear probe because provides enhanced imaging. If they are overweight or obese or of older age, we'll tend towards the phased array probe, which will allow a deeper field of view. Scans can also be done longitudinally, meaning with the ultrasound probe facing towards the patient head, or it can be transverse, meaning with the ultrasound probe in between the patient's ribs. Typically, and especially for beginners, the longitudinal images with the probe towards the patient head will be kind of what's taught first. This has downside in that there is rib shadowing, so it takes away some of the view of the ultrasound image, but can help clarify some of the findings, especially in the setting of subcutaneous emphysema. Whereas with the transverse scans, since there's no rib shadowing, you're in between the ribs, allows for a wider field of view of the pleura. And so different providers might have different preferences, but as long as you're scanning, or if you choose to do a complete scan over the entire chest, both should give approximately the same information. And so with the examination, lung ultrasound examination, what we're most interested in looking at is the parietal and visceral pleura. These are 5 micrometers thick and normally lubricated by a thin layer of pleural fluid. Normally on ultrasound, these layers are indistinguishable on the ultrasound. But most cases of respiratory disease, especially in adults, and some in pediatrics, except for kind of asthma and bronchiolitis, can involve the visceral pleura. And so the disease comes up to the pleura and can cause abnormalities of the pleural line, which are then recognizable on the lung ultrasound. So when we're doing the exam, there's a couple of tissues which we're ultrasounding through. First thing is the skin, and then subcutaneous tissue, as well as muscles. Depending on if you're doing transverse or longitudinal, you will have ribs. And then finally, there's the pleura underneath, followed by lung tissue and alveoli. Scanning over different regions, anterior, lateral, and posterior, allows you to look at different lung lobes, as well as regions. And then scanning superior and inferior allows you to evaluate the entire lung field. So when we're looking with the lung ultrasound, this is what the image typically looks like. You'll have your probe at the top, which is on the skin. Then you'll have subcutaneous tissue. You'll do, depending on the longitudinal or transverse, if it's longitudinal view, you'll have ribs, superior and inferior, muscles, and then the pleural line with air-filled alveoli underneath. And so again, this is an actual lung ultrasound image, and we have the soft tissue layer, and then we have superior rib, inferior rib, and rib shadowing underneath because the ultrasound waves are not able to penetrate the dense bone. And then we have the pleural line, which is made up of the visceral and parietal pleura with underlying alveola, alveolar septa, alveoli and septa, which abut the pleura. Normally, these alveoli cannot be seen under normal conditions. And then finally, we have what's called an A-line. This is reverberation artifact from when the ultrasound waves hit the pleural line, reverberate back or bounce back towards the ultrasound probe, and do so at differing times. And so this A-line occurs the same distance from the pleural line, from the A-line to the pleural line as the pleural line to the ultrasound probe, and occur at regularly repeating distances if you have sufficient depth. Normally, when doing lung ultrasound, we just need to be able to evaluate at a sufficient depth to obtain one A-line. Presence of the A-line ensures that the transducer is perpendicular to the pleura, which is what we need in order to be able to examine the lung. If the transducer is not perpendicular to the pleura, it produces an indistinct ultrasound pattern where neither A-lines nor B-lines are present. This, of course, can make it difficult to evaluate since landmarks are not distinguishable. Another point is that the pleural line should be generally parallel on the image or straight across. Otherwise, you can get, again, indistinct imaging patterns, which again make it difficult to make an assessment of the examination. And then finally, for quality assurance purposes, the area of interest should generally be in the center of the ultrasound image. If you have things on the periphery, should ideally slide the ultrasound probe so that you can see the area of interest in the center of the image. Of course, is going to be difficult when abnormality is just on the border of your imaging. Is important to remember that the pleural line should always be underneath the ribs and not on top of the ribs. If you see a pleural line which is above the ribs, this represents ultrasound waves which are being scattered at another air interface, most commonly subcutaneous emphysema. This will obscure the A-lines and pleural line as the ultrasound waves reverberate. And so you will have kind of pseudo A-lines reverberating from this pseudo pleural line or subcutaneous emphysema, which again occur at regularly occurring intervals and will obscure or erase the actual A-line, which occur below the ribs. This subcutaneous emphysema, which we also call E-lines, should not be moving with respirations like a normal pleural line would, and again, should be recognizable because they occur above the rib. And so this is, again, a review of a normal ultrasound. You have the A-line artifact, which is reverberation artifact from the pleural line, again, occurs below the rib, and on top you have subcutaneous fat and tissue. With normal respirations, the visceral and parietal pleura will slide against each other, as in this video, and appears as shimmering, or what can sometimes be called ants marching. If the pleura do not abut each other, then the sliding does not occur, and you will have a static pleural line, and you won't have this shimmering. This can be caused by air or fluid between the pleural surfaces. And M mode can be used to help better elucidate whether or not lung sliding is present. And so when lung sliding is present using M mode, we get what's called a seashore sign. And so we will have static, non-mobile appearance of the chest wall, which appears as a C. And then since the pleura are moving, it will kind of be hazy with the ants marching and shimmering. This is dynamic pleural sliding, appears as the shore with the bright pleural line in between. The presence of lung sliding is highly sensitive for pneumothorax, meaning presence of pleural sliding mostly eliminates presence of pneumothorax. But absence of lung sliding has low specificity. So in this example, we can see the image moving, but the pleural line is not moving as the patient is breathing. And so absence of lung sliding can occur in multiple different things, especially which we'll see in the intensive care unit, such as acute infection with a lot of inflammation, if patients have regional atelectasis or mucus plugging, as well as main stem intubation, in which air is not going into that particular lung. If patients have lung fibrosis or have had pneumonectomy or pleurodesis, they're not going to have lung sliding on that lung. And so the diagnosis of pneumothorax by lung ultrasound is highly dependent on the clinical context. Can be used to make the diagnosis, especially in an unstable patient, especially if you know they had lung sliding previously, might help you in narrowing your differential fairly quickly. M-mode can be helped to better elucidate whether or not there is lung sliding by something which is called the barcode sign. This is the non-mobile appearance of the chest wall as we had in the seashore sign. But then because the pleura are not together, not opposed, not moving during respirations, we have non-mobile appearance of the pleura and appears as a barcode all the way across the image. One specific finding for pneumothorax is called lung point. This is evident when a edge of normally aerated lung slides into view beneath the inner space where lack of lung sliding was present because of the pneumothorax. So it's normally aerated lung sliding over a region where there's pneumothorax. And again, this is fairly specific for presence of a pneumothorax. In these cases, M-mode will demonstrate a seashore sign, which is alternating with barcode sign. And so again, you have non-mobile appearance of the chest wall all the way across. You have the seashore sign, which alternates with the barcode sign, and then seashore sign as the lung slides into and out of view. One thing to be aware of is something called lung pulse, which is presence of cardiac pulsations, which are inducing pleural movement. This only occurs when the pleura are opposed to each other or in contact, is a finding which is similar to lung sliding and effectively excludes pneumothorax. So you can see in this image pleural shimmering, which is occurring at a rate which is roughly similar to the patient's heart rate. As we slide inferiorly while doing lung ultrasound, eventually the lung will abut the diaphragm. And what we end up seeing is a curvilinear diaphragm, and then the lung, which slides into and out of view. And obviously depends on which side you're on, which organ you're viewing. On the right side of the patient will be the liver, and the left side the spleen. So the diaphragm is a curvilinear hyperechoic line below which sits a solid organ. As the patient breathes, the diaphragm moves inferiorly as the lung expands and is well outlined in this picture because of a effusion. Sometimes it can be difficult to find this curvilinear diaphragm. And so what you might only see is what's called curtain sign or pseudo lung point. This is when the lung slides over the solid organ. And this can appear similar to the lung point that we see in pneumothorax. So it's part of the reason why it's always important to do our best to identify the diaphragm so that we're not making incorrect diagnoses. But we'll see in this image is a normally aerated lung sliding back and forth across the solid organ. And so in this image, we can see the solid organ and the normally aerated lung with the lung sliding across the image. And this is the region where we are seeing the diaphragm, the junction between the abdominal organs and the lungs. Is important to find the diaphragm because large pulmonary consolidations can mimic the echogenicity of the liver. This is called pulmonary hepatization, as this word right here. This is when you have such dense consolidation of the lung where it appears as a solid organ, and we'll see examples of this later on. And so coming back to our case example, I did lung ultrasound the first time I took care of the patient. And what we can see is some regions of normally aerated lung in the patient, one region where there was a consolidation, and one region where there's a small consolidation, but most of the regions have vertical haziness, which are called B-lines, which we'll talk about next. These B-lines are discrete vertical artifacts, which arise from the pleura and extend to the end of the visual field, move with the pleura, and obscure the A-lines. And so we can see a single B-line artifact in this image. So as a discrete vertical artifact comes from the pleural line, extends to the end of the visual field, and obscures the A-line. Also, we'll see that it moves with the pleura. We see B-lines when the interalveolar septa are widened, most commonly due to accumulation of fluid. This can be either with increased hydrostatic pressure or with increased capillary permeability. To be considered pathologic, typically we would need to see multiple B-lines within a patient rib space, and usually going to be in different lung regions. This is because fissures can also produce single B-lines, and these are not considered pathologic. So we have in this example a single B-line which starts from the pleura and extends down to the bottom of the screen and obscures the A-line. Z-lines are a normal ultrasound finding, which are frequently confused with B-lines. These do not extend to the bottom of the screen. They usually attenuate after a few centimeters and do not obliterate A-lines. They're typically less echogenic than the pleural line and not as discrete as B-lines, and may or may not move with the pleural line. These are, again, of no pathologic significance and can be seen in normal patients. And so in this example, we have single B-line artifact, and then the small hyperechoic vertical artifact is the Z-line artifact. We can see it doesn't extend to the bottom of the screen, doesn't obliterate the A-line. But we can see that both do move with respirations. Again, these are called Z-line artifacts and considered normal findings. And so here's an example of multiple B-lines, two B-line artifacts, which I've highlighted. And then with increasing alveolar edema, we get increasing number of B-lines, and they can become indistinguishable on lung ultrasound. We call these confluent B-lines. And so here's a nice example of increasing number of B-lines with increasing interalveolar fluid accumulation. from just a few B lines to multiple discrete B lines to confluent B lines. And so ultrasound scoring systems are increasingly being used in research and in clinical care in order to monitor patients over time. The most well-established, at least thus far in the pediatric literature, has been the lung ultrasound scoring system. This gives 0 points for normally aerated lung or a lung region with just 1 or 2 discrete B lines. We'll give 1 point for area with more than 3 or more discrete B lines. And then 2 points if you have multiple B lines or confluent B lines. And then 3 points if you have consolidated lung. And these are scored across 12 different regions, anterior and superior and inferior in the anterior region, superior, inferior in the lateral region, and then superior, inferior posteriorly on both the right and the left, getting score from 0 to 3. And this score has been used to monitor lung aeration, used to predict the need for increasing respiratory support, monitor response to medical therapies, has also been used to assess pulmonary edema as an endpoint of fluid resuscitation and an endpoint of diuresis, as well as assist in weaning from mechanical ventilation. And so coming back to our case, I will give the patient 0 points for the upper lung field on the right, 2 points for the lower lung field, 2 points in the upper lung field laterally, and then 1 point in the lateral lower lung field, and then 0 points for the upper on the right posterior, and 2 points on the right lower. And then adding all of these together, going through, gives a total lung ultrasound score of 18 at the time of the examination. And then following this examination, which we assessed as having pulmonary edema and being the most likely cause of the patient's respiratory distress, we initiated diuresis. And then 2 days later, he had near normalization of his lung ultrasound with only a few isolated discrete B lines in multiple lung regions, but much improved from prior. Next, what we're going to talk about is lung consolidations. We get decreased impedance from when there's lack of air beneath the pleural surface, and this can allow visualization of the lung parenchyma, which leads to the sonographic appearance of consolidations. And so parenchyma become well-defined when a lung consolidation is present. Consolidation is a descriptive term which has multiple potential etiologies, and is the clinical context in sonographic clues which may help us differentiate the cause of parenchymal consolidation. And so in pediatrics, the most common causes of consolidation, of course, are pneumonia, bronchiolitis, and atelectasis. And so the things which we're looking at when evaluating consolidations are the size, can be small or large, whether there's just one consolidation or multiple consolidations across different lung regions. Look at the border and characteristics of the consolidation. Look for the presence and characteristics of air bronchograms in the presence and characteristics of a pleural effusion. And so here's a example of a small consolidation. These have also been called in the literature subpleural consolidations. Can see this little coin-shaped punch-out region underneath the pleural line, which is an example of this in the accompanying CAT scan, and then confluent B lines underneath the small subpleural consolidation. This is an example of a large consolidation, also called in the literature lobar consolidation, as in this example. And so we can see in this region of the lung ultrasound with multiple air bronchograms all the way through the lung field. And so these are dynamic videos showing small consolidations and large consolidations. And so this differentiation between small and large consolidations is not super well defined or is not standardized across different studies. Although different studies will try to standardize this based on the size of the consolidation. In general or clinical practice, if it's small and just isolated to the pleura versus if it's going deeper, will help me differentiate between a small consolidation and large. And so, as I said before, large consolidations can mimic the echogenicity of the liver, especially when there's multiple error bronchograms and hypoechoic consolidations, as in these examples. And so, identifying the pleural line is extremely helpful in these circumstances. We can also describe consolidation based on the characteristics of the borders. And so we can have smooth, discrete consolidations, as in this example on the left, or ragged consolidations, as in the example on the right. And then, as I said, consolidations can also have bronchograms within them. The characteristics of the bronchogram can help us differentiate what might be causing the consolidation. And so you can have static air bronchograms, which are consolidated bronchograms, which do not have air moving in and out of them. These bronchograms will tend to move with the lung as it slides inferiorly and superiorly, as compared to dynamic air bronchograms, which will appear to be moving at a different rate than the lung, because they're caused by fluid within the bronchus, which is moving at a different rate compared to the lung. And so we can see in this example, there are air bronchograms up here, but move with the lung. And then in this example on the right, we'll see air bronchograms, which are arising from this region and moving towards the ultrasound probe as the lung descends. And so you can see them moving this direction. And again, static air bronchograms are typically going to be caused by collapse of lung around a bronchus, whereas dynamic air bronchograms are typically going to be caused by fluid within a bronchus, which is moving with respirations. One thing which has been described in the literature, more so in the adult literature, is using color Doppler to help differentiate air bronchograms from blood vessels. And because blood vessels also may show up as kind of hollow tubes on the lung ultrasound. And so putting color Doppler on can demonstrate whether or not there's blood flow, which would make it a vessel. And can also be helpful in identifying abscesses, which typically will demonstrate internal vascularity, but with the vessels kind of more isolated to the outer perimeter of the consolidation. This is not used too much, though, in pediatric lung ultrasound, because if patients, in order to get good images on the color Doppler, should typically do a breath hold. Many patients, which we are doing in pediatrics, are not capable of this and are too dyspneic in order to pause their breathing, or not old enough in order to be able to cooperate with the examination. This, of course, will cause a lot of artifact in the examination. And I've only been able to find one paper which describes use of color Doppler in pediatrics was a anesthesia case report of 3 patients in which they induced atelectasis after intubation and demonstrated that you can see blood vessels within the pulmonary parenchyma, and then that the consolidations disappear with increasing patient PEEP. Otherwise, in other clinical studies, I've not seen this much reported, but it's something which is reported in the adult literature. And so consolidations can also be associated with presence of pleural effusions, which are collections of extrapulmonary fluid, or is possible that a pleural effusion causes pulmonary consolidation. And so both looking at the characteristics of the pleural effusion as well as the characteristics of the underlying lung can be helpful in differentiating what the cause is. And so in this example on the left, we'll see simple pleural effusion, hypoechoic region exterior to the lung parenchyma, which is this consolidated region. But the lung itself kind of moves back and forth and shakes with respiration as the diaphragm descends, as opposed to the video on the right, which also has a effusion, but as the lung moves inferiorly, does not have that shaking motion. And so this on the left side, with kind of dynamic movement of the lung with respiration, is more suggestive of atelectasis, as opposed to the image on the right, which is more suggestive of a pneumonia. And so these are just 2 examples of simple pleural effusions. Again, the simple pleural effusion is a anechoic collection of fluid external to the lung, which separates the visceral and parietal pleura. And so there's a small one here, and then a small one here on the right side. Complex effusions either can be hypoechoic collections of fluid, or can see septations within the collection of fluid. These complex pleural effusions are going to be more suggestive of acute infection, empyema, or pneumonia. One time or one instance in which I can see color Doppler being beneficial in pediatrics is when you have multiple septations within a pleural effusion, or is very complex. Effusion is hard to differentiate whether or not it is parenchyma or an effusion. If you put color Doppler on to an effusion, or empyema should not have blood flow within it, whereas the pulmonary parenchyma will. And so this is one case, even kind of independent of patient's respiratory rate, where it might be helpful to use color Doppler to differentiate complex effusion from consolidation in pediatrics, though this has not yet been described very well in the literature, pediatric literature. And so just in summary, consolidation characteristics may support different underlying etiologies. Typically, atelectasis would be associated with volume loss, static air bronchograms, and movement of the lung tip, especially if there's a effusion. Bronchiolitis is more likely to be associated with multiple small consolidations with multiple affected lung regions and few to no bronchograms. Of course, depends on if patient has atelectasis, this might change. And then pneumonia is more likely to be associated with larger consolidations, preserved lung volumes, shred sign or ragged borders of the consolidation, as well as dynamic air bronchograms. If there's an effusion, is more likely to be complex with pneumonia and more likely to not have movement of the lung tip within the effusion. There are multiple adult studies which have used decision trees to help differentiate the cause of respiratory distress and respiratory failure. In adult studies, these typically demonstrate very high sensitivity and specificity in differentiating the most common causes of respiratory distress and failure in adults. And so this particular one, which is one of the first, called the Blue Protocol, looks at presence or absence of lung sliding. If is present and there are multiple B lines, this is suggestive of pulmonary edema. If there is lung sliding in primarily A lines, then they recommend analysis of the venous system, looking for DVT. If DVT is present, this is suggestive of pulmonary embolism. If DVT is not present, this can be suggestive of asthma or COPD. If there's posterior pleural effusion, would be suggestive of pneumonia. If there's no lung sliding and there are B lines, this is suggestive of pneumonia. If there are no lung sliding but A lines, most likely pneumothorax. And this type of decision tree has also been adapted for pediatric patients, as in this example from 2019, Dr. Tripathi. But so far, most of the studies which have just looked at lung ultrasound in order to try to differentiate patient cause of respiratory distress and failure have generally shown lower sensitivity and specificity compared to what has been shown in the adult studies and the neonatal studies. Obviously, some differences between studies, but most of the adult literature shows sensitivity and specificity in the high 80s or 90s, whereas pediatric literature, just using lung ultrasound, not including history and physical exam, is much less well established. And so this is why I say we should be using clinical history, physical examination, and the lung ultrasound as an ancillary study in helping us determine what's causing patients' respiratory distress or failure. And so in summary, normal lung ultrasound will have presence of A lines, which is a reverberation artifact from the pleural line. You will also see, depending on if you're using transverse or longitudinal view, superior and inferior ribs. And if patient is old enough to have ossification of the ribs, you will have underlying rib shadowing and then subcutaneous soft tissue. We can get B-line artifacts, which are vertical artifacts that arise from the pleural line, extend to the end of the ultrasound view, move with the pleura, and obscure the pleural line. And then there are many types of consolidations. Consolidation is just a descriptive term. Need to take into consideration the patient's history, physical examination in determining the cause. But some of the things that we look at are the size of the consolidation, whether it's small or large, occurring in multiple different lung regions, whether or not the borders are smooth or if they're jagged. And then assessing the pleural line, which can be abolished in many disease processes, including inflammation, pneumonia, anytime the pleura are not opposed to each other, such as in pleural effusion or in pneumothorax. We will get non-mobile appearance of the chest wall and of the underlying pleura, which leads to what's called barcode sign. And this compares to when we have mobile appearance of the pleura, we get seashore sign, where you have no movement of the subcutaneous tissue, and then hazy movement of the pleura. So this is the C and then shore. And then finally, effusions are hypoechoic collections of extra pulmonary fluid. Simple effusions are typically anechoic, tend to be in dependent lung regions. And then complex fluid collections are hypoechoic, can have septations, and can be in any lung region, depending on what the cause of the effusion is. One of the major limitations to be aware of lung ultrasound is that the abnormality must reach the pleural surface in order to be identified on the lung ultrasound. So one of the things what we commonly see, or at least I commonly see in X-ray reads, is parabronchial thickening and parabronchial consolidations, as commonly seen in things like asthma and bronchiolitis. These are not readily identified, not identified on lung ultrasound because they don't reach the pleura. And so many times patients with asthma or bronchiolitis may have relatively normal looking lung ultrasounds. Although it has been described with increasing severity of bronchiolitis, presence of more small consolidations, even large consolidations if patients have atelectasis, which may be associated with outcomes. This is primarily in emergency department literature, which is looking at patient disposition and utilization of respiratory therapies. And if there are any questions, I will be happy to take them. Thank you.